Welcome. In this session, we are going to discuss acquired lacrimal drainage obstruction. The other forms of acquired lacrimal disorders such as trauma, infection and neoplasia we are going to discuss in the next session. Epiphora is overflow of tears over the eyelid margin and down the cheek. Epiphora can be due to lacrimal outflow obstruction or lacrimal gland hypersecretion, which may be primary or secondary. In pseudoepiphora, tears do not overflow, but there is a sensation of excess tears in the eye. Epiphora is usually worse in the morning, in the outdoors, and in cold weather. When a patient presents with the chief complaints of watering in the eyes, we have to inquire whether the epiphora is intermittent or persistent and whether there are periods of remission in between periods of epiphora, whether there is associated presence of discharge and/or blood with the water, whether the epiphora is unilateral or bilateral, whether there are associated symptoms of allergy or dry eye, both of which may cause watering in the eyes, whether there is current or previous episodes of pain. We have to also inquire about previous history of ocular infections, dacryocystitis and sinonasal diseases, previous history of application of topical medications such as epinephrine, pilocarpine, ecothiophat iodide and 5-fluorouracil, and all of these can cause punctal and/or canalicular obstruction. Previous history of probing and facial trauma, and presence of sinonasal symptoms such as congestion, anosmia, epistaxis, and headache. Examination of a patient complaining of epiphora includes measurement of the tear meniscus height and whether there is any presence of discharge in the tear film. Signs of ocular surface irritation such as entropion, trichiasis, presence of staining, a low TBUT count, Schirmer's testing, presence of facial asymmetry suggesting congenital or traumatic NLD blockage, orbital signs such as proptosis and diplopia suggesting either lacrimal involvement by an orbital process or orbital involvement by a lacrimal pathology. Clinical evaluation for outflow obstruction includes examination of the puncta, the lacrimal pump, the lacrimal sac, and the nose. Examination of the puncta includes assessment of the position of the puncta in the tear lake, and normally the puncta are directed posteriorly towards the tear lake, and with the eyes of the patient closed, the puncta are not visible normally from outside. Detecting presence of aplasia, occlusion or stenosis of the puncta or obstruction of the puncta by adjacent conjunctivocalasis, that is a loose fold of conjunctiva or enlarged caruncle. Malfunction of the lacrimal pump is suggested by presence of facial nerve palsy, horizontal eyelid laxity and/or ectropion. The lacrimal sac area should be palpated for the presence of a mass, and if a soft compressible or non-compressible mass is found, it suggests the presence of a mucocele resulting from obstruction of the nasolacrimal duct, and if a firm mass is found, it suggests tumor in the lacrimal sac area. As we have discussed in the previous session, digital pressure on the lacrimal sac area is recommended in every patient presenting with epiphora, and if it results in reflux of mucoid or mucopollutant discharge through the puncta, it confirms the presence of complete NLD obstruction and obviates the need for further testing to detect NLD patency. Nasal examination, preferably endoscopic, is recommended to rule out conditions which can block the nasal end of the nasolacrimal duct, such as chronic rhinitis, deviated nasal septum, turbinate impaction, and polyps or tumors. Diagnostic tests for lacrimal outflow obstruction includes the dye disappearance test, in which fluorescein is instilled in both the eyes and the tear films are examined with the cobalt blue filters on the slit lamp. Absence of significant dye in the tear film 5 minutes after installation of fluorescein indicates functional or physiological patency of the lacrimal outflow pathways. But if the lacrimal outflow pathway is functionally or physiologically blocked, there will be significant amount of fluorescein in the tear film 5 minutes after installation of the fluorescein. However, intermittent causes of outflow obstruction such as rhinitis and dacryoliths cannot be ruled out with dye disappearance test. The excess dye-stained tears can be seen to overflow usually from the medial canthal region and then laterally onto the tear trough inferior to the lower eyelid. But in patients with upper eyelid dermatocalasis, the excess dye-stained tears can also be seen to overflow from the lateral canthal region, and this is called the upper eyelid beak syndrome. Dye disappearance test is particularly useful in children and in unilateral cases. Dye disappearance test can be followed with the Jones fluorescent dye test, but this is not routinely done nowadays. In Jones 1 test, the inferior meatus is swabbed to check for presence of fluorescein, and this is presently done with nasal endoscopy performed 3 minutes after installation of the fluorescein into the tear film. And presence of fluorescein in the inferior meatus suggests physiological or functional patency of the lacrimal drainage pathway. If fluorescein is not detected in the inferior meatus in the Jones 1 test, it suggests anatomical or physiological block of the lacrimal outflow pathways, and then Jones 2 test is performed, in which fluorescein is flushed out of the conjunctival sac and lacrimal drainage pathway is irrigated with clear saline, and if there is failure of this fluid to pass into the nose, it suggests an anatomical block of the lacrimal outflow pathway. If fluorescein is found in the inferior meatus in the Jones 2 test, it indicates that the fluorescent dye reached the lacrimal sac during Jones 1 test and suggests physiological patency of the upper system, and also suggests that the site of the physiological block is probably in the lower system. However, if there is absence of fluorescein in the inferior meatus in the Jones 2 test, it suggests that dye did not reach the lacrimal sac during the dye disappearance test, indicating physiological block in the upper system. So the interpretation of Jones 2 test is based on whether dye has reached the lacrimal sac at the end of dye disappearance test. The lacrimal irrigation test or the lacrimal syringing test is commonly performed, and it is very important to understand the interpretation of the results of the lacrimal syringing test. The lacrimal syringing test is done by application of topical anesthesia into the conjunctival sac, followed by dilatation of the punctum with punctal dilator, while noting presence of stenosis at the puncta. Then the 27G cannula attached to a fluid-filled syringe is introduced into the canaliculus through the puncta, while noting any obstruction in the canaliculus, while lateral traction is applied to the eyelid with a finger of the other hand, and the fluid in the syringe is then injected into the canaliculus. In the lacrimal irrigation test, if fluid passes into the nose without any reflux, the interpretation is an anatomical patency of the nasolacrimal duct. However, this result does not indicate physiological patency of the nasolacrimal duct, because in the lacrimal irrigation test, the fluid is injected under pressure, which is absent in natural circumstances. When fluid passes into the nose with resistance along with reflux of the fluid through the opposite canaliculus with or without discharge, the interpretation is that of a partial NLD block. And when fluid does not appear in the nose with reflux of fluid with or without discharge through the opposite canaliculus along with a palpable lacrimal sac, the interpretation is that of a complete NLD block. When there is a complete NLD block along with a functional valve of Rosenmuller preventing retrograde flow of fluid, there will be a palpable and painful distension of the lacrimal sac. When fluid does not appear in the nose along with reflux of clear fluid without discharge through the opposite canaliculus without any distension of the lacrimal sac, the interpretation is that of a common canalicular block. And if we are not able to advance the cannula through the canaliculi with reflux of clear fluid without discharge through the same puncta, the interpretation is of a canalicular block. In contrast to pediatric patients in whom probing of the entire lacrimal outflow pathway is done, in adults diagnostic probing is restricted to the upper system, that is from the puncta to the lacrimal sac. This is because in most pediatric patients with epiphora, the block is at the distal end of the nasolacrimal duct, which can be opened by probing the nasolacrimal duct. Whereas in adults, obstruction of the nasolacrimal duct is due to fibrosis of the nasolacrimal duct, and so nasolacrimal duct probing does not help in adults. Diagnostic probing of the upper system in adults is indicated when lacrimal irrigation test suggests a block proximal to the lacrimal sac to find out the location of the block proximal to the sac. Prior to any surgical intervention for epiphora, a nasal examination is recommended, and it should preferably be an endoscopic nasal examination. An endoscopic nasal examination is also recommended following a failed DCR or CDCR procedure to detect the status of the ostium, as we will be describing later in this session. Imaging studies such as DCG, scintigraphy and CT or MRI are indicated when digital pressure on the lacrimal sac area does not produce any reflux through either puncta, and lacrimal irrigation test result is inconclusive. Imaging studies is also indicated when an unusual etiology is suspected, such as a lacrimal sac neoplasm. Dacryocystography or DCG is digital subtraction imaging after lacrimal irrigation with contrast agent. DCG determines anatomical patency of the lacrimal outflow pathway and also detects level of block or stenosis in the lacrimal outflow pathway. Indications for DCG include complete or incomplete lacrimal outflow obstruction, but when location of the block cannot be determined clinically. It is also indicated when we suspect adnexal lesions causing compression or deflection of the lacrimal sac or the nasolacrimal duct, and when we suspect lacrimal sac tumor which shows filling defect on DCG. In Dacryoscintigraphy, radionucleotide containing eye drops are instilled in the conjunctival sac followed by scintigraphy, and the radionucleotide technetium-99m pertechnetate is usually used. In contrast to DCG, which determines anatomical patency of the lacrimal outflow pathways, Dacryoscintigraphy determines physiological patency of the lacrimal outflow pathways and also detects delay in passage of the radionucleotide, if any. Dacryoscintigraphy suggests the level of the physiological block but does not show the lacrimal passages as clearly as DCG. CT scan and MRI are indicated for trauma, sinonasal diseases, neoplasms and craniofacial deformities, and CT scan can be combined with lacrimal irrigation with contrast when it is called a CT-DCG. After discussing the clinical evaluation methods and the diagnostic testing modalities for acquired lacrimal drainage obstruction, we will be discussing the acquired obstructions at the punctal, canalicular and nasolacrimal duct levels separately along with their management. Acquired punctal disorders causing epiphora can be punctal stenosis, which can be caused by cicatricial conjunctivitis such as Stevens-Johnson syndrome and ocular cicatricial pemphigoid, infections such as herpes simplex virus, and iatrogenic causes such as glaucoma eye drops, antiviral drugs, cautery and plugging treatment for dry eye, radiation therapy in the periocular area, or administration of topical and systemic chemotherapy such as 5-fluorouracil. Treatment of punctal stenosis includes punctal dilatation, but the effect of punctal dilatation is usually temporary. Punctoplasty is a snip procedure incising the wall of the ampulla, which is the proximal vertical portion of the canaliculus. If punctoplasty fails, stenting of the canaliculus is required. Punctal malposition is usually due to ectropion when we will have punctal eversion, and punctal eversion is actually the most common cause of punctal stenosis. Punctal enlargement is usually iatrogenic following aggressive punctal dilatation or punctoplasty, and an enlarged punctum fails to occlude upon eyelid closure and thus fails to develop negative pressure, which is essential for the lacrimal pump to function appropriately. Punctal obstruction can occur due to adjacent pathological processes such as conjunctivocalasis, an enlarged caruncle, or tumors of the eyelid. As we have discussed, treatment of punctal obstruction is intubation if punctoplasty fails, or if intubation fails, a CDCR is required, which we will be describing shortly. In acquired canalicular obstruction, the level of obstruction in the canaliculus can be detected by a soft stop during diagnostic probing. We have discussed about soft stop and hard stop in the previous session. Causes of acquired canalicular obstruction include lacrimal plugs meant for treatment of dry eye, and these plugs can be punctal plugs which may migrate into the canaliculus, or intracanalicular plugs, and both these can cause canalicular inflammation, infection and scarring. The plug may need to be surgically excised along with a segment of the canaliculus, followed by repair of the remaining canaliculus. Medications such as topical idoxuridine and 5-fluorouracil and systemic docetaxel can cause canalicular obstruction, and the canaliculae may need to be intubated early to prevent progression of obstruction if these medications need to be continued. Canalicular obstruction can occur in cicatrizing conjunctival inflammatory processes such as ocular cicatricial pemphigoid, Stevens-Johnson syndrome, and graft versus host disease. However, there may not be any epiphora due to the associated severe dry eye in these cicatrizing conjunctivitis processes. Infections such as herpes simplex virus keratoconjunctivitis and isolated canaliculitis, which we will be discussing in the next session, can also cause canalicular obstruction. Canalicular trauma can lead to canalicular scarring, and timely repair can prevent scarring and complete obstruction of the canaliculus, as we will be discussing in the next session. Resection of a neoplasm in the medial canthal area can lead to canalicular discontinuity, but complete resection of the tumor and absence of tumor recurrence must be confirmed before canalicular reconstruction is attempted, usually after 3 to 6 months. And punctal and canalicular obstruction are also known to occur in chronic staphylococcal blepharitis. A partial canalicular obstruction can be relieved by intubation or stenting, as we have discussed, and for a proximal localized canalicular obstruction, excision of the obstructed area and re-anastomosis over a stent can be done. For a distal localized canalicular obstruction or a common canalicular obstruction, canalicular trephination can be done, and this is a picture of a canalicular trephine. The trephine is inserted up to the soft stop at the point of obstruction and then rotated through the obstruction till achieving a hard stop in the medial wall of the lacrimal sac, followed by intubation. However, trephination is less effective for localized proximal obstruction. For common canalicular and lacrimal sac obstruction, Canaliculodacryocystorhinostomy is an option in which the scarred area is excised and the canaliculi are attached either to the lateral wall of the lacrimal sac or the mucosa of the lateral nasal wall with placement of a stent. For extensive scarring of the upper lacrimal drainage system, a Conjunctivodacryocystorhinostomy is required, in which the nasal mucosa is exposed as in a Dacryocystorhinostomy procedure, which we will be discussing shortly. Then a passage is made from the caruncle to the middle meatus of the nose with a trocar, followed by insertion of a Jones tube in this passage, but the Jones tube after final placement should not touch the nasal septum. The photographs here show a Jones tube and the trocar system used to create the channel for the Jones tube. Following CDCR with placement of a Jones tube, postoperative care is essential to prevent occlusion of the Jones tube and inflammation or infection of the tract of the Jones tube. Daily nasal saline lavage and snuffing of artificial tears through the Jones tube is advised, and periodic clinic-based removal, cleaning and reinsertion of the Jones tube should be recommended. Sleep apnea patients on continuous positive pressure ventilation may be bothered by retrograde airflow to the eye through the Jones tube, and migration and extrusion of Jones tube is common and needs early replacement to prevent closure of the passage of the Jones tube. Acquired obstruction of the nasolacrimal duct is diagnosed during the lacrimal irrigation test as discussed previously, and it is important to remember that not all acquired NLDOs are benign in nature. Causes of acquired nasolacrimal duct obstruction includes involutional stenosis, which is the most common cause of acquired NLDO, and involutional NLDO occurs in an older age group. Females are twice as frequently affected with involutional NLDO as males, and involutional NLDO is more common in lower socioeconomic groups. Concretions in the lacrimal sac, also known as dacryoliths, may also cause lacrimal duct obstruction, and dacryoliths are usually idiopathic in nature but may be caused by long-term use of epinephrine eye drops and infections such as actinomyces and candida. Dacryoliths typically cause intermittent NLD obstruction with or without episodes of dacryocystitis. Impaction of dacryoliths in the nasolacrimal duct can be painful, and dacryoliths can be missed in routine X-rays but can be picked up in DCG. Dacryoliths are easily removed during the DCR procedure. Sinonasal diseases such as polyps, chronic allergy, and deviated nasal septum can cause nasolacrimal duct obstruction, and more serious involvement of the sinonasal pathways such as sarcoidosis, granulomatosis with polyangiitis, also called Regenous granulomatosis, and ulcerating midline lymphomas can cause NLD obstruction. NLD obstruction can also occur following nasoorbital fractures and sinus and nasal surgery. Neoplasm as an etiology of nasolacrimal duct obstruction should be considered in all NLDO patients, particularly in middle-aged patients with unilateral epiphora. Risk of neoplasm as an etiology of NLDO is higher with younger age and male sex, with bloody tears also called hemolacrima, with lacrimal swelling extending above the medial canthal tendon, and with a previous history of sinonasal neoplasm. When neoplasm is suspected as an etiology of NLDO, a nasal endoscopy may help in diagnosis, and imaging and biopsy needs to be done. Management of neoplastic etiology of nasolacrimal duct obstruction involves complete resection of the tumor with clear margins. For a benign tumor, a DCR or a CDCR procedure can be done as appropriate without further delay. But for a malignant tumor, lacrimal apparatus reconstruction is done 3 to 6 months later after there is no evidence of residual tumor or tumor recurrence. Iatrogenic causes of nasolacrimal duct obstruction includes lacrimal and punctal plugs migrating into the nasolacrimal duct, and they need removal during the DCR procedure. Incompletely removed lacrimal stents can also obstruct the nasolacrimal duct, and radioactive iodine therapy for thyroid cancer can cause obstruction of the nasolacrimal duct because of the presence of sodium iodide symporter in the lacrimal sac and NLD mucosa. Lower dose of radioiodine used for Graves' hyperthyroidism but not for thyroid cancer treatment is not known to cause NLDO. Management of a patient with acquired obstruction of the nasolacrimal duct includes stenting of the entire lacrimal passage, particularly in a patient with partial NLDO complaining of persistent epiphora. But Dacryocystorhinostomy or DCR is the most commonly performed and standard procedure for NLD obstruction. Indications of DCR in NLDO include recurrent dacryocystitis or infections of the lacrimal sac, which we will be discussing in more detail in the next session, chronic mucoid discharge, dacryoliths, and congenital dacryocele, which we have discussed in the previous session. DCR creates an anastomosis between the lacrimal sac and the nasal mucosa through a bony ostium. DCR can be done externally through a transcutaneous approach, and this is recommended in patients with dacryoliths or with a suspected neoplasm. DCR can also be done internally through an endonasal approach, which provides a faster recovery with no external scar formation. External DCR starts with anesthesia and hemostasis with lidocaine and adrenaline injection in the medial canthal area, along with intranasal anesthetic and oxymetazoline or epinephrine. The skin incision is made 10 mm medial to the medial canthus, starting just above the medial canthal tendon and extending inferolaterally along the tear trough. Dissection is carried down to the bone, exposing the anterior lacrimal crest, posterior to which lies the lacrimal sac, and during this dissection, angular blood vessels should be avoided. Periosteum over the anterior lacrimal crest is reflected laterally along with the lacrimal sac. After the lacrimal sac has been reflected laterally, a bony ostium is created in the lacrimal fossa adjacent to the medial wall of the lacrimal sac. A trachwire periosteal elevator is used to enter through the lacrimal fossa along the suture line between the lacrimal bone and the frontal process of the maxillary bone. The frontal process of the maxillary bone and the lacrimal bone constitutes the lacrimal fossa. Then a Cadison punch is used to enlarge the passage through the lacrimal fossa to create a bony ostium of appropriate size between the lacrimal sac and the nasal cavity. Intervening anterior ethmoidal air cells and portions of the anterior turbinate may have to be removed to create a bony ostium of appropriate size. This is a trachwire periosteal elevator, and this is a Cadison punch. Then the nasal mucosa visible through the bony ostium is incised, and the adjacent medial wall of the lacrimal sac is also incised. During incision of the lacrimal sac, care should be taken to not injure the opening of the common canaliculus into the lacrimal sac. And a lacrimal probe can be passed from either puncta to the nasal cavity to determine patency of the upper lacrimal drainage system. Then the anterior flaps, and if possible also the posterior flaps of the lacrimal sac and the nasal mucosa, are sutured together. Nasal packing is not required routinely if there is no bleeding at the end of surgery. A bicanalicular lacrimal stent can be placed extending into the nasal cavity as has been described previously. However, a bicanalicular lacrimal stent has not been shown to increase the success rate of a standard DCR procedure for NLD blockage. The skin is then closed. If there is hemorrhage intraoperatively or postoperatively, patient is asked to sit up, nasal packing is done, and blood pressure is lowered. Following DCR, patients are asked not to blow the nose for 7 days to reduce the risk of secondary hemorrhage from clot dislodgement. For endonasal DCR, appropriate selection of patient with adequate intranasal space is required. The nasal mucosa over the area of the lacrimal sac is identified, and for this fiber optic probe may be passed through the puncta and the canaliculus to trans-illuminate the lacrimal sac. The nasal mucosa is then incised above the inferior turbinate and anterior to the middle turbinate. The incised nasal mucosa is then removed, followed by removal of portion of the frontal process of the maxillary bone and the lacrimal bone with a bar or a punch. The bony ostium made should not extend posterior to the posterior lacrimal crest or above the lacrimal sac area. Then the medial wall of the lacrimal sac is excised, and the open lacrimal sac is marsupialized through the bony ostium into the nasal cavity. Additional intranasal procedures such as septoplasty may be required and can be done through the endonasal approach, and bicanalicular stenting through the puncta into the nasal cavity is done at the end of the endonasal procedure. Causes of failure of DCR include inadequate size or location of the bony ostium, fibrosis and occlusion of the bony ostium, the risk factors for which include history of trauma, active or postoperative infection, autoimmune diseases, and hypersensitivity to the stent material. DCR may fail due to iatrogenic injury to the common canalicular opening into the lacrimal sac or iatrogenic injury to the nasal septum. Inadequate removal of inferior portion of the medial wall of the sac may also cause failure of DCR, and this is called the sump syndrome. Management of failed DCR includes nasal endoscopic removal of fibrovascular obstruction at the bony ostium followed by intubation, or a redo surgery may be required with revision of flaps followed by intubation. During surgical correction of failed DCR, mitomycin can be applied to the area of the bony ostium. Endoscopic lacrimal duct recanalization has also been described, in which the nasolacrimal duct is directly cannulated through a punctal approach and viewed. And with this technique, focal obstructions of the NLD can be identified and removed. Thank you for listening.